So first, as you can see the screen. So if you see the checklist of the marking list of the college, you can find. I just need it to become bigger so you can see it now. You can find in history station. We have 2 history station, 4 for clinical knowledge, 8 for clinical and technical skill, but you can find another 4 and 4, so 8 mark for communication skills and professionalism. So it is important to have good communication. So again, this is station mark. History taking, it is different from station to station. Clinical knowledge 4, technical skill 8, communication and professionalism 4 and 4. Uh, in history taking, whatever you make, you need to ask about main complaint, analyze the main complaint. You ask about nausea, vomiting, whatever, coughing, loss of appetite, and the loss of weight to exclude malignancy, bowel movement. Other system must ask past medical history, chronic disease like hypertension, diabetes, dyslipidemia, past admission to hospital or surgery, family history, allergy, social history, smoking, and drinking alcohol. So some student in exam concentrate in the first part, like analysis of the complaint and go to through differential diagnosis and forget past the medical history, past admission, family history, allergy, social history. So he can easily lose 4, 5, 6 mark in this. So it is important to ask about all item of the history. It is history station, whatever we ask about, so you must fulfilled all criteria of history taking. I start by first scenario, so anyone can be volunteer. Uh, this is the script, so it is 55 years old. Anyone need to start, by the way? We can start by
تمام.
anyone. Ahmed, okay, can start. 55 years old male with severe epigastric pain radiated to the back after attending his daughter wedding and drink a lot, 9 cups of alcohol. He usually drink but a small amount on weekend. He is married and have 2 children, live with his wife and children. So can
Okay.
you start? I mimic the simulated patient so they can ask me.
Okay. Good afternoon. I'm Dr. Ahmed, of surgical team. May I confirm
Okay.
your name and age?
Yeah, I am Mr. John. I am 55 years old.
Nice to see you, Mr. John. Today I was asked to ask you some questions regarding your condition. Is that okay with you?
Yes, can.
What seems to be the problem today?
No, I have yesterday I attend my daughter wedding. I drink a lot of alcohol, so I have pain in my upper part of abdomen.
First of all, congratulations for your good daughter's wedding. I
Okay,
must.
thank you.
Can you tell me more, elaborate more about this pain?
Uh,
Where exactly? Okay.
no, it is in the upper part of my abdomen.
Okay. Does this pain increases or is it the same?
No, it is increasing when I drink alcohol or drink or eat, but it is now the same.
Okay. What is the character of this pain? It is numbing or
It,
burning?
it is colicky in nature, so on and off.
Okay. I'm so sorry about your pain. Do you feel well now? Do you need any painkiller?
No, thank you. The hospital give me okay. I have a cannula and they give me the painkiller.
Okay. From a scale from 1 to 10, 10 is the worst pain. Where can you put your pain in this scale?
It was 7 now because I take medication. It becomes 3.
Okay. Can you tell me, have you had this condition before?
No, it's the first time.
First time. Do you have any chronic illness? You take any medication for any
No,
illness?
no, no. It's still you finish the pain now.
Uh, uh,
Okay, so from this script, first you make the good thing because you have some empathy, so they congratulate him about his daughter wedding. See, this is good. What is your diagnosis in your
uh,
mind?
pancreatitis,
But you made some very important character of pancreatitis. What is this?
pain radiated to back.
Yes, so you need to ask where is patient pain radiated? So pain radiated to my back and decrease by which position can decrease it?
Leaning forward.
All right, okay. So it is important. It is, that's the one big problem in the exam. The student knows the scenario, maybe know some details in the scenario, and they know that it look like pancreatitis because the patient drink alcohol. So at least you need to concentrate in this. So this pain is radiated to the back and relieved by leaning forward. Okay. So after
Okay.
that, okay, go on. After that, what you need to ask?
About any allergies for
No, you
drugs or
ask
food.
about chronic disease. Just one by one. Just
Okay.
start. Yes.
Do you have any chronic disease you take drug for it?
Okay, if you ask like this, is the wrong question because I don't know what you mean by chronic disease. So what is
Okay.
you mean by chronic disease? So you need to justify.
Okay. I mean like diabetes or hypertension.
Okay, so your question, are you have any chronic illness or disease like diabetes, hypertension, dyslipidemia? Yes or no? Okay, so this is
Okay.
must like don't ask the question. Are you have any chronic illness? So it is vague question because in pediatric maybe bronchial asthma is a chronic disease. Many years in Egypt maybe rheumatic heart is a chronic disease. Okay, so this is about chronic disease. What else you need to ask?
About uh, any past hospital admission,
No past
allergic,
admission. What you mean by allergic to what?
allergy for specific drugs or food.
Okay, so you need to justify also. So are you allergic to any medication or food? No, or yes, I have allergic to seafood. So you need to just become more specific. Okay, apart from allergy, what else you need to ask?
Any previous surgeries,
No.
and a family history of being like this in one of your families.
No, but my father died from heart attack.
Oh, I'm so sorry about that.
Okay, thank
Uh,
you.
okay. We are going now to ask you some personal questions. Do you smoke?
Yes, I smoked 10 cigarettes per day for the last 20 years.
Okay. Do you drink alcohol?
Yes, I drink 1 can of alcoholic beer every day since 20 years.
Yeah. What about physical activity and diet?
What you
Uh,
mean by physical activity, like go to gym or okay, I am active. I go to walking, I go to my club maybe once per week.
okay, great. Uh, mm, Nothing about sexual. Okay, I've
Okay,
just.
finish.
Mm.
Okay, so you ask about allergy, family history, social history, everything. Okay, so it is important in any history if you remember back, if you go to back here in any history, what topics you missed here?
Mm. Uh,
Important in any disease, important in any history.
other system review.
Other says, what else?
Oh, المalignancy.
Loss of weight, loss of appetite. So it is important, whatever the case, you need to ask about loss of weight, loss of appetite. Even in acute appendicitis, even in any disease, especially in old people. So you need to ask about loss of weight, loss of appetite. And also, don't forget to ask about other system. Can you ask me about other system, please? Go on.
Okay. Do you notice any shortness of breath or any cough recently?
No, no,
Uh, do you feel your heart beats?
no.
Do you wake at night for air for fresh air?
You mean like have difficult in breathing at night?
Yeah.
Yes, no, no.
Do you feel comfort on lying flat? How many
Y-
pills you
No, no,
see?
I'm okay. No problem.
Do you have any other bowel abnormality like diarrhea or constipation or any?
Constipation, no diarrhea and constipation.
Okay.
Urine,
Okay. If for urine, do you feel any pain
uh,
during your?
just ask about pain, change in color, and increase frequency. No.
Okay.
Okay. So again, we back again. History taken is easy station. Also, many students fail on it. I don't know why, but don't forget to ask about other system. Have about 2 mark. Of course, you ask about medical disease, chronic illness. You need to justify or specify it. So don't ask the patient, "Are you have any chronic illness?" You must give example. Family history, again, allergy to medication or food, and social history, smoking and drink alcohol. Okay.
Okay.
Uh, if you do that in exam and you loss of appetite, 1 mark, other system 2 mark, 3 mark. If you miss some from this, can be 1 or 2 mark. So it is easy to lose a mark if you concentrate of the main disease, but it is okay. What's your diagnosis? As you
My
know
main,
that you take a history in 6 minutes. After that, the bell ring or say 3 minutes remaining, and after that, what is your diagnosis?
my main diagnosis is acute appendicitis. I may also consider
No,
complication.
no, no. What is acute appendicitis or acute pancreatitis?
I'm sorry, I'm acute pancreatitis.
Acute pancreatitis. Okay. So can be others, but acute pancreatitis is in the top. What is the investigation? It is useful for your diagnosis.
I start with lab investigation like full blood count and
No, no,
so,
we don't ask. We don't ask you what is the investigation you need to do. We ask you what is the more specific investigation in this patient to
more
how to
specific,
confirm acute pancreatitis.
CT cause contrast
No, CT with contrast is an advanced. How to know that it is acute pancreatitis by lab investigation?
by serum lipase.
Amylase and lipase. So we will do amylase and lipase. Okay. Apart from amylase and lipase, what other investigation you will do? So you can start by baseline investigation. Like what? Can you enumerate to me what the other investigation you need to do? Lab investigation and why?
Okay, I start with full blood count and electrolyte, urea and electrolyte, and lactate and ABG,
Okay. All right.
and inflammatory markers.
Uh-huh. Okay.
For imaging, I, I think ultrasound is not helpful for pancreatitis.
No,
I
no,
start.
we're still in the lab. Dr. Ahmed, if you answer that in exam, you will be in critical situation because
Okay,
you just enumerate. We don't need you
okay.
to enumerate. You say, for example, full blood count. What you are looking in full blood count?
I'm looking for hemoglobin.
Hemoglobin
For
and in this patient in particular, looking for some leukocytosis. You say
leukocyte.
lactate. Why you do lactate?
The lactate is an indication of acute inflammation. The
It is inflammatory marker and severity of the inflammation. You see inflammatory marker like CRB and ESR. So it is of value to do that or not?
other inflammatory marker other than lactate.
Yeah, lactate now is okay because lactate is not inflammatory marker. It is for severity of sepsis. It is one of the criteria of sepsis used now. But you mentioned inflammatory marker. It is routine. For example, if this patient acute appendicitis, we diagnose
Uh,
clinically as acute appendicitis, you do inflammatory marker in your practice. You do it or not?
not routine. It is not non-specific. Maybe
Okay.
not.
So if it is not routine and not non-specific, so don't waste your time and mention something non-specific and you waste the discussion. The examiner discuss you with these topics and at the end you don't have a mark because it's not in checklist. But what is important you miss? You say full blood count, lactate. What else is important in acute pancreatitis?
Calcium level, albumin, and glucose.
What is okay? So what about calcium? What happened to the calcium? Is become
Uh,
decrease.
okay.
Okay. What is the value to measure the blood sugar?
Blood sugar may be also increased. Maybe increased.
Increase. It is
Increased.
indicated. It is important, especially if the patient is non-diabetic. Okay. So when you answer about or you tell about investigation, if you enumerate like you mentioned before, you don't take a mark because if you say full blood count, urea electrolyte, liver function test, all these, I don't know what you mean.
Mm.
But you need to justify, like, I will do full blood count looking for leukocytosis or low hemoglobin. I will do calcium, and calcium is low. Blood sugar, it is important, especially if the patient is non-diabetic. I will do or ask for arterial blood gases. All this is important. After that, you mention radiology. What radiology you will do or you ask
Uh,
for?
okay, abdominal ultrasound with contrast.
Abdominal ultrasound. Usually ultrasound have no contrast, doctor.
I'm sorry,
CT
CT
can have.
it's
Okay,
free
can do
contrast.
CT, can CT. Contrast is also not important because they don't show the pancreas, but no problem. Just CT and ultrasound. Chest X-ray is important or not?
Yes, important. And
Why?
patient may acute respiratory distress syndrome.
Syndrome. Okay. What is etiology of the acute pancreatitis in your patient? This patient, what we mentioned just now.
Uh, Etiology in this patient is alcoholic, but in general,
Uh,
goes to
is alcoholic. What is other causes of the increase, other causes of acute pancreatitis?
okay. Most important cause is gallbladder stone, and
Gallbladder is so.
consider also in inflammation like with mumbus or coccidiosis virus and the
Okay,
traumatic.
in England, maybe Mumbus can. In most of the country of the world, Mumbus is not cause pancreatitis. Why? Suppose you are
Uh,
in country like Malaysia, for example, they don't have pancreatitis due to Mumbus. Why?
I think what's called herd immunity or something.
No, no, because they have vaccination. In Egypt and Malaysia and Saudi Arabia, they give Mumbus vaccine, measles, mumps, rubella, MMR at the age of 9 months. So it is give for life immunity. So the usually viral pancreatitis due to Mumbus is very, very rare. But in England, they don't have these vaccines, so they can have it. All right. So, is any
Okay.
score system, for pancreatitis, the severity of the case? Any score system easy for you, easy to remember?
Uh, Glasgow score.
Glasgow
Glasgow and
scale or
Ransom.
score? Okay. No, just choose one. What? Choose one.
Okay.
You know it. Which one you choose?
Glasgow score.
Glasgow criteria or Emery, just write VANCREAS, so just 8 letter, and B for BO2, A for age more than 55, N for neutrophil, calcium, C for calcium, which is low, renal function is increased, liver enzyme, but not amylase and lipase, A for albumin or acidosis, and S for sugar. Okay, how to treat this patient?
I start support his systems by giving by two wide bore cannulas and giving fluid and monitoring of this fluid by CBB and urinary catheterization and support
Okay,
nutrition.
just one by one. So why is this patient come to you? Why is this patient?
Mm,
What is the patient presentation? Why he come to you?
pain. First thing is pain.
Ben. So what is the first answer? What is the first answer?
Yeah, okay. يبقى analgesia, oxygen, and
Okay.
then
All
I
right.
start
So
support.
it is important to know why brings the patient to you. If the patient have a fracture and you speak about airway, of course, airway and cannula is very important. Of course, we put a cannula, resuscitate the patient. But if the patient having pain, so we treat by analgesic first. You can put a cannula, give analgesia, nothing by mouth, nasogastric tube. You mentioned that you how to monitor the fluid. How to monitor the fluid? You mentioned that by what?
By CBB and urine output.
Okay, so urine output by flow chart. What is normal urine output for a patient like 50 kilogram
Normal from 0.5 to 1 milli per kg per hour.
per hour? Okay, all right. What is normal central CVB?
Uh, from 2 to 8 centimeter
What is
water
centimeter water? In your hospital, you measure by centimeter by centimeter water or by saline?
by saline, no by saline.
Okay, so the correct answer, it is measured by saline. Although we called it water, we teach it in college by water, but actually, if you say to the nurses, we measure by water and you put water, the patient will die for hemolysis. So just put in your mind that it is Saline, not water. Okay, so free resuscitation oxygen. I don't mention what is controversy like octreotide or somatomidine or all these because it's still not evidence-based medicine. Okay. It is good you don't mention in Egypt for many years the student usually mention something called the ICE, which is idea, concern, and expectation, which is not actually used in England and I think is not used in Egypt, maybe used recently, but this is not in the classic way for presentation of the what is called it of the history taking. All right, so it is
Yes.
good. All right. Thank you, Dr. Ahmed. Any comment from the others? Any comment? Anyone need to
I
clarify
think
something?
in associated features, we can ask about MI.
What you mean by MI? Ischemic heart or what?
MI related to ischemic heart, yeah.
You can ask if you have just ask
gastric
if you have any chest pain is okay. You know, I think you are
Abortomy
looking
pain.
for other differential diagnosis. So you need to ask about acute cholecystitis or ischemic heart or this. It can, but don't wait. This is clear that this patient is look like acute pancreatitis. But in systematic review, you need to ask about you have any chest pain. He tell you no. It is also better because the pancreatitis usually with a gallbladder disease. You need to ask about jaundice. So if you have jaundice, if this pain radiated to right shoulder, can ask, but no much detail because it is clear it is acute pancreatitis. Okay. Sometimes you ask about differential diagnosis, so it is another issue, but it's not necessary to ask the patient about other disease. Just to take it simple. I know that in the most of the other books you have it, they insisted to ask about many differential diagnosis. Sometimes say four differential diagnosis. This is can, but usually if we need to ask about differential diagnosis, we ask you. So, but just in systematic review, you need to ask about chest pain, jaundice, and any pain radiated to right shoulder. Any other question? Are you clear now, Dr. Hamza, or not? Okay, I know that many of the courses or many of the staff who teach history taken, they take it more difficult, more complicated than I think, which is not our aim. It's our aim in the Royal College of Surgeons of England, how to take a proper history, including all items, social history, family history, allergy, and others. Okay?
Yeah,
So
according to the material of the course, we finish the 6 minutes in analysis of the main complaint and the associated features.
Say
We
again.
don't have more time. I think according to the teaching of the courses, we analyze the pain and the associated features and the 6 minutes time off. We don't have more time to ask about both medical and drugs and social and idea of concern.
Okay, so what we put for this mark for in the answer sheet? So what we give you in this mark?
I think
I just tell you, Dr. Hamza, checklist of the history taken is a fixed list. Is not designed from station to station, and the item of history taking is a fixed. So suppose, and this is why. It is easy to fail in OSCE because suppose you analyze the pain, you reach the diagnosis. So how much mark you take it now? Out of, if you suppose it is out of 15, for example, because it's still 5 for question. So how much I give to you?
Yeah, you lose a lot of marks according to both medical.
Yes, you can lose.
Yeah.
You can lose. I connected to. I account to you. Social history on mark, allergy on mark, family history on mark, 3, past medical 4 mark, other system 2 mark, so 6 mark. So you lost 6 mark. Simply, so easy. It's very common. I attend the exam many times and usually the student do like that, so it is okay. And this is why the exam, it is not possible to all the student pass or not all fail. So this is why we must have some people fail. So if the patient or the student don't take the whole item of history, it is easy to fail. It's not fail, but have less mark, because this is exams, you count the number of the mark, so he have less mark. Okay. But if you count, we
Okay.
can count for you. So for example, we can see in 6 minutes how to manage. Okay, I just show you something easy. I need to share with you. So this patient is a second scenario, is a 65 years old man, is seen in outpatient clinic, complain of pain in the left lower limb after walking. Okay, so you can start.
Okay.
We can count the time now. All right.
Okay. Good morning.
Good morning.
Hello,
I
I'm
am
Dr. Hamza,
Mr.
one of
Master. Yes, hi, Dr.
I'm Dr.
Hamza. I am
Hamza, one
Mr.
of the
John.
surgical doctors. Okay, nice to
Yes.
meet you, Mr. John. Today I
Mm.
have been to ask you a few questions regarding your conditions. Is that
Okay,
okay
you
with
can
you, Mr.
start.
John?
Yes, can.
Yeah. How
No,
can I help you today, Mr. John?
no, I have been in my left leg.
Yeah, really sorry to hear this, Mr. John. This must be
Okay,
frustrating for you.
okay.
Would you like to give you a painkiller?
No, it's already given me painkillers.
Yeah. Mr. John, how's it been start? Suddenly or gradually?
Notice suddenly I usually walking every day about 2 kilo. When I walk for 1 kilo, I found severe pain in my left side of my leg.
Yeah, Mr. John, could you please describe the pain for me? It's like dull, aching.
It is the cramping pain.
Yeah, sorry to hear this, Mr. John. Mr. John, is the pain all the time or comes and go?
No, come after I walking for 1 kilo, 1 kilometer.
Yeah, yeah. Mr. John, does anything make the pain increase?
If I still walking after this 1 kilo, but I need to stop 5 minutes. After that, I can walk again.
Yeah, really sorry to hear this. Mr. John, anything, do you have recent trauma
No
to
trauma.
your, yeah. Could you please put the score on the scale from 1 to 10, which 10 being the worst pain?
Yeah, it is about 5.
Yeah. How about the pain affect your life in general, Mr. John?
No, I am retired, so nothing is not affecting my life, but I unable to continuous walking with my friend.
Yeah. Mr. John, do you have any other pains in other joints in your body?
No, no,
Do you have any other complaint of pain related to other joints?
no.
Hello?
Yes, no, 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 no. I
Hello?
hear you. Yes, I hear you. No, no. أنا سامعك.
Yeah.
I hear
Mr.
you.
John, before I go any further questions, what is the cause, do you think? What do you think the cause is?
Okay. No, I ask you what you think this case.
Listen, I
Okay.
want to
All
ask
right.
more this.
I don't know the cause because you are the doctor, so I don't know the cause.
Yeah.
Okay.
Okay. Mr. John, do you have any leg weakness or numbness?
Yes, have a little numbness, yes, but no weakness.
Yeah. Do you have any loss of sensations in your groin area or
No,
difficulty in gaining erection?
I have lots of weak sensation below knee in the left side. Erection is okay.
Yeah. Mr. John, do you have recent trauma to your back?
No,
What is your job, Mr. John?
No, I am a retired teacher. I teach English.
Do you lifting a heavy things?
No.
Yeah. What about your past medical history, like hypertension, diabetes mellitus?
I have high cholesterol, and the doctor advised me to take a medication. I don't take a medication. And he also asked me to change my diet. I don't change my diet. I have hypertension. I take medication for that. I don't have diabetes.
Yeah. Mr. John, any previous surgery recently?
No surgery.
Yeah. Mr. John, do you notice any unintentional weight loss?
No loss of weight at all.
Okay. And what about your appetite recently?
No, it's okay. Normal appetite.
Yeah. Mr. John, what about your drugs? Do you take any drugs?
You need medication. I don't take. I just take
Yeah,
medication for hypertension.
other than related to hypertension.
No, but doctor asked me to take the cholesterol medication. I don't take it.
Yeah. Does anyone in your family have similar problem, like being in the leg?
No, but my father died from cancer colon.
Yeah, really sorry to hear this, Mr. John, about
Thank you.
your father.
Thank
Mr.
you.
John, do you have any shortness of breath or difficulty to
No,
getting breath?
no,
Any cough pain, Mr. John, or cough swelling?
no.
Okay. بس أنا
Okay, all right. بص يا دكتور حمزة, you are okay, but you are not have social, what called it social intelligence. When you start read the script, the scenario, pain in the left lower limb after walking. So first impression, what you expected this station about?
أنا كنت I suspect mechanical,
Mechanical.
also osteoarthritis.
Okay, so what is common in England disease can cause this?
According to the history taking, I think osteoarthritis related to hypertension and the cholesterol.
Okay, so if I mention to you that I walking for 1 kilo and need to stop
Vascular?
5 minutes, so this is a vascular case. Okay.
Yeah.
It is not you start to ask about left heavy object, you ask about something, this is not related. This patient is walking and stop walking, so this is intermittent claudication. So if this case is intermittent or ischemia, so what is the important topic you need to ask about? Suppose the patient, yes.
About the vascular recent surgery to exclude any ambulance.
All right, okay. So in vascular surgery, you need to ask about loss of hair, skin change, any ulcer, infection between toes, intermittent claudication, as we mentioned. You mentioned, so why you ask about impotence or erectile dysfunction? Why?
Sciatica, related to sciatica.
No. Sciatica, your question is correct, but your explanation is incorrect. If you ask about erectile dysfunction, can be thrombus occur in bifurcation of aorta, what we call it Loris syndrome, and it is common if they have a patient come to you and he say I have erectile dysfunction, so looking for diabetes, looking for thrombosis in the bifurcation of aorta, what we call it Loris syndrome. So this is why we ask about erectile dysfunction. So if we go back again to this station, so it must look like that. If you go to this station, it is better to look like that. So first, you start by information, what you need. but it is important to start about skin manifestation of ischemia, loss of hair, skin change, any wound or ulcer, infection between toes, fungus infection, intermittent contraction, any muscle atrophy, any loss of sensation, any temperature change. After that, you go to systematic system like shortening of breath, cough, cardiovascular, urinary system, GIT, rheumatic, all this. After that, you look like the others, past history, allergy, social history, smoking, family history. And you can see this patient is smoke a lot. If you ask about smoking, so it is most probably, and when I tell you twice, this patient, I don't take a medication of cholesterol. So what is the suitable next question? If I tell you I don't take a medication, so why you don't take a medication? Maybe simple answer, I don't need. He just need to give explanation why this patient have ischemia. Because he have high cholesterol, he don't take a medication. The doctor ask him to avoid fast food or fatty diet, and he don't follow this regulation. Okay? So it is easy, is look easy. Okay, so this is
But
just
I start related to mechanical. I don't start related to vascular.
if it is a mechanical, so we give to you to have patient have a trauma or something like that. Okay, but
Yeah.
you know that in England, because the people is living long periods, so they have aortic aneurysm, they have a lot of ischemic disease. Ischemia is very common there. Okay. But it's okay, no problem. But you need to, what is the investigation you will do for this patient?
Firstly, I will do duplex.
No, doctor,
ultrasound.
don't jump. When you ask you in general, not specific, so you need to start by full blood count, looking for full blood count, any abnormality. I'm looking for liver function test. I'm looking for cholesterol. I'm looking for lipid profile, of course, and after that you can ask about angio and others. What else you need to do?
Duplex CT angio if indicated for surgery.
Okay, you mean that angiogram for the lower limb is not necessary CT because we don't do CT angio for lower limb. You can see the picture now. You see the picture.
Yeah.
What is your diagnosis?
Popliteal artery.
Left popliteal artery occlusion. How to manage this case? If you are a vascular surgeon, how to manage this case? After resuscitation and the painkiller and the baseline investigation, what vascular surgeon do in this patient?
I think above knee. No.
No amputation. This patient have good collateral. This patient is lucky, have a good collateral. Although the popliteal is closed, but have a good collateral, you can see. No, this is popliteal is closed, but he have a good collateral. This is lucky patient. This is why this patient come to you walking. So how to manage this? This patient have thrombus or embolus here. So first you need to remove the thrombus by embolectomy. Second, if you have narrowing, you do balloon dilatation. After that, you put a stent. Okay, so it is easy. We'll have something obstruct, you remove the obstruction. If you have narrowing, make balloon dilatation, and after that, put a stent. Nowadays, we don't do vascular bypass grafting or all these or all the system. Although in the past, 10 years ago, some surgeon believe that it is below the knee is difficult to put a graft because of the movement of the knee, but nowadays they can put a graft. No, not put a graft, can put a stent. Okay. You say sorry many times. When you start, doctor, you ask about it is frustrated you. What is the aim to tell that? What is the aim that if I say I am have a pain, so it is sorry for that, it is frustrated you. What is the aim from you? What you expected that from us? Yani, why you tell that?
I think to show the empathy according to the pain which affect your life. But when ask about the pain affect your life. You
Uh-huh.
said you are retired and not affect your life in general.
Yes, okay. All right. Can, no problems. Okay. And of course, okay, no problem. Okay. So usually what you speak, no problem, but you just need to concentrate on the topic. Don't jump from topic to topic. Put your mind vascular is important. So maybe
I think
because
the mistake I do I deal with the case according to mechanical, not vascular.
but I think we don't have mechanical scenario, or we have, I don't know.
Leg weakness or leg pain related
Yes.
to mechanical. So I ask about saddle paresthesia and also erection problems.
Okay. So it is important.
And lifting heavy things.
Mm.
All things
Okay,
related to
can
mechanical
be.
pain.
But usually it is important that if you have an exam, one of the causes of failure of many students that they expected, or they have the what called impressions that they know the station. Okay. And sometimes because we examine in any about 400 students, we can find some students answer us the answer of the another scenario. You understand the idea. So, for example, we have a common scenario of the patient third day after left hemicolectomy, and the same scenario 10 days after left hemicolectomy. 3 days after hemicolectomy have chest pain, 10 days after hemicolectomy have chest pain. What is the difference between these two scenarios? If the patient have after left hemicolectomy for diverticulitis or for cancer, and after 3 days have chest shortening of breath. The other
3D,
patient,
I think pulmonary embolism.
say again.
3 days
Yes.
after recent surgery, I think pulmonary embolism.
Okay. I examine about 200 students in India, in Hyderabad, and they say pulmonary embolism. But it is wrong answer. Why it is wrong answer?
Fat embolism?
No, it is wrong answer. Why it is wrong answer? If pulmonary embolism to occur, how many days he need? Pulmonary embolism to occur, you must have deep venous thrombosis first. Deep venous thrombosis occur in 7 days. Pulmonary embolism need more than 10 days. If the patient is the orthopedic and they have intraepidurally nail or nowadays liposuction surgery, and can patient after 3 days can have fat embolism. It is correct. But in this patient, if I repeat the scenario again, patient 3 days after hemicolectomy have shortening of breath. What's your diagnosis? So it is not pulmonary embolism, not fat embolism. What it could be?
Pulmonary edema?
Make it simple. Just lung atelectasis or chest infection. Just simple. Okay?
Okay.
But you can string your answer is, that 200 students, they give you the same answer you mentioned, pulmonary embolism, which is wrong. So it is important because why they tell the wrong answer? Because we have in the previous exam the same script but after 10 days. You got the idea. So they believe that they will repeat it. We repeated the same script but just change 3 days instead of 10 days. So instead of become pulmonary embolism, just chest infection. If I ask you how to manage this chest infection, what is your answer?
Chest infection.
Yes.
According to after discussion multidisciplinary team, and then call the microbiologist and take sputum for analysis. And after this advice of microbiologist, give the patient broad spectrum antibiotics until the results of culture come out.
Although Dr. Hamza, your answer is look good, but it is the same, is also unlogic. First, in your hospital for chest infection, you have multiple disciplinary team in your hospital. You expected that in England for chest infection, they make a team to treat chest infection?
No.
Okay, so this is how it is. We have multidisciplinary team for cancer, for something, but not for chest infection.
Okay.
Microbiology can, sputum can is okay, but if we think simple and you ask for chest infection and arterial blood gases, chest X-ray and arterial blood gases, and ask the help of the chest physician, this is more logic answer. You got the idea, okay?
Okay.
If you are in England, you expected that they make sputum analysis. If you are in
Sorry?
India, if you are in England, in UK, United Kingdom, you do sputum analysis.
Okay.
You do it or not do it?
I think you do.
Why? Is this is TB is common in England nowadays, for example? Is not common.
No, I take sputum for culture and sensitivity in general.
For
to,
bacteria,
to,
you mean for bacteria?
to
you mean-
identify the main causative organism.
Okay, can. It is not routine, but it is not wrong, but it's not routine. Okay. I think if you have this question in exam, so it's better just ask for chest X-ray blood gases and ask the help of the chest doctor. Don't dig yourself in some details. And because if you say something very strange to us, some doctors or some examiners can ask you what you mean by that. Okay. All right. So it is easy, but I think Dr. Hamza, you take it more complicated. So this is you must take it more easier. All right. We have the third scenario, and we have Dr. Ahmed. The third scenario is altered bowel habit. I think you can see it now. Bleeding upper rectum or altered bowel habit. Okay. You see, just a simple, like 65 years old man attend an outpatient clinic, complain from altered bowel habit. Altered bowel habit mean constipation and diarrhea. Okay.
I can see the scenario.
You don't see. Okay, just a minute. Okay. You can see it now.
Yes. Okay. Now, yes.
Okay.
So shall I start?
Yeah, you can start. Yes.
So good morning. I'm Dr. Ahmed, and I am one of the surgical doctors. May I confirm your name and age, please?
Yeah, I am Mr. John. I am 65 years old.
Nice to meet you, Mr. John. Well, today I've been asked to take to talk with you about your health condition, and I will be asking some questions and taking some notes. Is it okay with you?
Okay, no problem.
Okay, great. So can you start by telling me what is the problem with you today?
Yeah, in the last 2 months, I have sometimes constipation, sometimes diarrhea. I mean by constipation that I go to wash. Usually, normally, I go to washroom or go to toilets maybe twice per day. If I have constipation, I go to once per 2 days. If I have diarrhea, I went to the washroom 5 times per day. So this has happened in the last 2 months. Sometimes constipation, sometimes diarrhea. Okay.
Okay. Is it associated with any pain in your tummy or your abdomen?
No pain.
Okay. Is it associated with bleeding from the rectum? Or
Yes,
from,
I have my stool is mixed with blood.
Okay. Any other colors like mucus or any discharge with this
No,
stool?
sometimes they have mucus and dark color stools.
Okay. Have you noticed any weight loss or any loss of appetite?
Yes, I lost 5 kilo in the last 12 months, but no loss of weight.
Again, sorry, you lost weight or
I lost 5 kilo, but no loss of appetite. I lost
Okay, great.
5 kilo in 1 month.
Okay. Have you noticed any joint tear on any leg pain?
No joint pain.
Okay. Any skin problems like yellow color or something?
No.
Or any eye problems?
No eye problems.
Okay, great. Do you have any past medical history like diabetes or hypertension?
No,
Okay. And have you had any surgery before?
no surgery.
Do you took any drugs?
You mean for what? For
Medications for any conditions, or
like what?
for example, for pain, for
No, don't take any medication.
okay. Have you had any history of hospital admission before?
No.
Okay. Do you have any family history of similar condition?
Yes, I think my grandfather died from cancer colon.
Sorry for the stories for your grandmother.
Okay, thank you.
Okay. Okay. Do you smoke or drink alcohol?
Yes, I smoked 10 cigarettes per day for the last 30 years, and I drink one alcoholic cans of beer every weekend.
Okay. What is your job?
I am a retired teacher.
Okay. With whom do you live?
Yeah, I live with my wife.
Okay. Do you have any allergy for medications or food?
No.
Okay. Finally, I would to ask some questions. Have you noticed any chest pain or shortness of breath?
No.
Okay. Any heart palpitation or
What you mean by
shoulder?
palpitation? You mean that
I
I
mean,
hear my
yeah.
heart faster? No.
Okay. Do you have any problem with urination?
Like what?
Like pain or change in color?
Change in color or increase frequency? No.
Yes. Okay. Yes, this is the end of my questions. Thank you.
Okay. So you have one mistake, Dr. Ahmed. Okay. What's your diagnosis?
I think it's inflammatory bowel disease or cancer colon.
No, choose one. Inflammatory bowel disease or cancer colon.
Inflammatory bowel.
Okay. But you mentioned, I tell you that I lost 5 kilo in the last 1 month. And this is short
Well,
period.
okay. Because in inflammatory bowel, it can be associated with weight loss as well. But there is no appetite loss, you mentioned. And,
okay. I think you ask about joint pain and skin problem and eye looking for ulcerative colitis.
Yes, it was normal, yes.
But you are wrong also. You know why you are wrong? Okay.
Why?
So if I need to make this scenario ulcerative colitis, how can I make it?
For ulcerative colitis,
yes, it is the same, but I tell you, I have this condition. I have bloody diarrhea, not constipation and diarrhea. I have bloody or bleeding rectum for the last 2, 3, 5 years.
Okay.
Okay. So the long period, so it is ulcerative colitis. But we are short period, so it is a cancer. But you miss one important topic, diverticulitis. What you need to ask to exclude diverticulitis?
I asked it for the abdominal pain. There was no pain.
Abdominal pain can. What is more specific in itis? Diverticulitis.
Fever and signs of inflammation.
Fever. So you don't ask about fever. So if you are in the exam scenario and you don't ask about fever, so the examiner asks you why it is not diverticulitis. Diverticulitis can have bleeding rectum, so it is important to ask about fever. Okay. So when you ask about colonic symptom, you ask about, we start one by one. So start amount bloody or something, no problem, painful defecation, alter bowel habit. We have something like tenesmus, incomplete evacuation with cancer. Sometimes you have fecal incontinence. You need to ask about fecal incontinence. You ask about loss of weight, loss of appetite. Don't forget fever to exclude diverticulitis. So fever is very important. Tenesmus also can be important in complete evacuation. Fecal incontinence is important. If this patient have fecal incontinence and have a cancer, so where is the site of the cancer?
Usually it is rectal.
Is the sphincter in the rectum or anus?
Anal cancer. Yes.
So if the patient have fecal incontinence, so it is anal. If the patient, what is the so it is important to ask about fecal incontinence. You miss it. You missed tenesmus. If I count you for the topics I needed for cancer colon, so you miss tenesmus, you miss fecal incontinence, you miss fever. So you miss 3 important topics. you put in your mind it can be ulcerative colitis, but from the beginning it is not ulcerative colitis, because ulcerative colitis in this patient, if they're 65 years old and have ulcerative colitis, maybe have presentation more than 10 years, maybe 20 years. So it is longer time. We don't mention that. Okay, you ask about other system. Don't say palpitation. Palpitation is a medical term. But the other, you ask about everything. You miss something very important. Any patient have bleeding, whatever the cause, you need to ask about aspirin or oral anticoagulant.
Okay.
Because
Yes.
sometimes the patient take high dose of oral anticoagulants, INRs 2 and 3, and have hematuria or bleeding of the rectum or whatever the cause of bleeding. So it is important to exclude that. Okay. You
Okay.
ask about other systems. So what is your, we can write differential diagnosis if you take the history like this: cancer colon, diverticulitis, and something very rare called angiodysplasia, which is occur after age of 70. It is like AV malformation. Okay. So
Okay.
again, to exclude diverticulitis, not diverticulosis by fever, angiodysplasia difficult to diagnose. All right. What is the investigation you will do apart from lab investigation and the baseline investigation? What else you need to do?
Colonoscopy and biopsy.
Colonoscopy and the biopsy. So colonoscopy to diagnose diverticulosis or diverticulitis, diagnose a cancer, and sometimes you can find familial adenomatous polyposis. If you find the patient have familial adenomatous polyposis and one of polyposis changed to cancer, so what you will do for the rest of his family?
They should go for screening
Why?
because usually it is familiar.
It is autosomal dominant. Okay, so this patient, suppose they have 20 brother and sister. So this is 20 brother and sister is have familial adenomatous polyposis, and you make ultrasound and make colonoscopy, you found they have familial adenomatous polyposis. So at which age you need to remove the colon?
Between 20 and 30.
Make it 30 is okay. Why?
As prophylactic for cancer colon.
Because if it's stay till age of 40, 100% is become a cancer. Okay?
Yes.
Because
Yeah.
familial adenomatous polyposis, we say it is precancerous condition. Ulcerative colitis is have risk of malignancy. What is the difference between both term, precancerous and risk of malignancy? What is the difference?
Precancerous lesion can be transformed into a cancer cell or cancerous cells. But while the risk
Just one by one. Precancerous lesion can go to cancer in what percentage?
in 100%.
100%. And ulcerative colitis have risk of malignancy. What you mean by risk of malignancy?
It increases the risk of developing cancerous cells, but not necessarily to happen.
Okay, it is, yes, correct. It is like smoking cigarette can cause cancer lung, but not necessarily all the smoker have a cancer lung. But all the people have carcinoma in situ. All the people have familial adenomatous polyposis 100% if they stay at age of 40. So they have a cancer in 100%. Okay.
Yes.
How to stage if I say I have a cancer? What is the common site of cancer colon?
Sigmoid colon and
Rectosigmoid, yes. All right, okay. How to, if I say patient have a cancer colon invading urinary bladder, what is T? What is T? Like which TNM staging for that?
T3.
No, it is invading. It is like come out from the colon, so it is T4. If I just maybe have a picture here, no picture. Okay, that like this. Okay, if it come out, it is T4. If it is superficial, it is T1. If it is invading muscularis propria, T2. Penetrating muscularis propria, T3. So why it is important to know that?
To set the management plan.
No, the management, you know this TNM staging before or after surgery? This picture is taken, this picture in front of you is taken after surgery or before surgery? So it
After
is
surgery.
after surgery, so it is not a management plan. TNM staging you can know for prognosis. Like for example, if you have Dukes like this, so can say Dukes A is good prognosis, 90% 5-year survival. Dukes D, if the patient have metastasis or liver metastasis, they have 15%. Okay. So back again, what is the common site of metastasis in the cancer colon?
Bone and
No, bone not. What is the common site? If the patient have cancer colon, they have liver metastasis. Why?
liver, yes, because of the portal circulation.
Portal circulation. Okay. So this is why staging TNM or Dukes staging, we have Dukes staging, we have TNM staging. The important of both is just to know prognosis. It is TNM staging. Just remember T2 invading, T3 penetrating vascularis propria, T4 go to the other organ. N0 no lymph node, N1 3 lymph node, N2 more than 4 lymph node, M0 no metastasis, M1 metastasis. How to know this patient have metastasis or not? What is the investigation you will do?
Whole body CT scan.
What you mean by whole body?
Brain
No. We don't do that. We just CT, TAB, thorax, abdomen, and pelvis. Okay, not whole body scan. We don't do. We lost the time and the money, a lot of money, to do that. So it is just CT, thorax, abdomen, and pelvis. Okay. I just show picture. What is this? What is this could be? Or this one? What is this? Colonoscope.
Multiple ulcers in the colon.
Not ulcer. The ulcer is ulcer. This is not ulcer, not a foramina. What is this? Anyone?
Melanosis coli.
No. Just make it easy. This is diverticulosis.
Polyps.
Diverticulosis.
Okay.
This is Bauch's. You can see it from outside. I don't have the picture from outside. This one and this one is diverticulitis. Okay, this look like lotus plant. You don't use for it, but it is diverticulitis. This is familial adenomatous bulbosis, multiple polyp. This is single polyp or multiple, but not much multiple polyp. But this is multiple polyp. Okay, this is single polyp. All right. So our aim from this session is just to know if you need to take a history, you need to take a history as a proper history. So including all item of the history. Okay. I just, all right.